Ladies and gentlemen.
This episode is sponsored by Advanced Skills Company, the official agent of JPI Healthcare in Iraq. I personally use the products of JPI Healthcare in my clinic for years now, and throughout the years, these products have been amazing in terms of providing excellent image quality at the lowest radiation dose possible, and they are durable, reliable, and efficient. I recommend, if you are looking to establish your radiology practice, whether in a clinic, in a center, or in a hospital setting, to go to the JPI Healthcare website, see their products for yourself, and then call Advanced Skills Company if you are in Iraq, and these guys will provide the best possible solutions, whether in terms of hardware or software. I will leave the contact information in the video description, and don't forget to use the magic word highlights in radiology, because you will get a 10% discount on all JPI Healthcare products till the end of 2024. Hello everyone, and welcome to a new episode of Highlights in Radiology Season 2. In today's episode, we are going to talk about a very interesting topic in musculoskeletal imaging, which is aneurysmal bone cyst, also known as ABC. Before we start, I want to remind you to subscribe, like, share, and tell your friends about us. This is Dr. Ahmed Dia Abdul Wahab, and this is Highlights in Radiology Season 2. Stay with me. Aneurysmal bone cyst, or ABC, is an expansile lesion of bone containing thin-walled, blood-filled cystic lesions. The most common presentation is usually progressive pain and swelling, with rapid increase in pain severity over 6 to 12 weeks. In spinal lesions, it may cause cord compression, presenting as radiculopathy or quadriplegia. Also nerve root impingement, and in 10% of cases, it presents as scoliosis. Pathologic fractures seen in about 20% of cases, and if it is close to a joint, there will be limited range of motion, and usually there is a history of trauma. It is most commonly seen at 10 to 30 years of age, patients with 76% presenting under 20 years of age. It's slightly more common in females than males. ABC is a benign, locally destructive lesion with local recurrence in about 10 to 20% of cases. The recurrence is increased in young patients with open growth plate. There is no malignant transformation, and it never metastasizes. ABC can be easily mistaken for a malignant bone neoplasm, pathologically and radiologically. ABC is neither a cyst nor a neoplasm. It represents a reparative process triggered by a tumor or a trauma-induced vascular process. It can be either primary or secondary. Primary ABC arises de novo, in bone without recognizable pre-existing lesion. It can be caused by trauma, while secondary ABC arises in a pre-existing lesion, which can be either benign neoplasm, like giant cell tumor, osteoblastoma, chondroblastoma, or fibrous dysplasia, or can be malignant neoplasm, like osteosarcoma, chondrosarcoma, or malignant fibrous histiocytoma. It represents 6% of primary bone lesions. It's important to identify the underlying lesion, which will change the treatment. Treatment options include curettage, cryosurgery, bone grafting, and resection. Of course, there is a risk of bleeding during surgery, so other options include preoperative embolization, which can cause complications like aseptic necrosis. Other options include also percutaneous Iffy block injection and radiation therapy, which have a risk of sarcomatous degeneration. So what radiology can offer in cases of aneurysmal bone cyst? Well, first we have to know the common locations of ABC. ABC is seen in the long tubular bones in around 70 to 80%, like in this example of ABC within the fibula. Also, it is seen in the pelvis in about 5 to 10%, as in this case of ABC within the right superior pubic ramus. Also, it is seen in the posterior elements of the spine in 15% of cases. It may cross the intervertebral disc and can involve more than one vertebra, as in this case of aneurysmal bone cyst seen involving the spinous process of C2 vertebra. Hands are involved in 10 to 15%, as in this case of aneurysmal bone cyst involving the fourth metacarpal bone. Regarding location within the bone, it is seen in the metaphysis in 80 to 90% of cases, and in the diaphysis in 10 to 20% of cases. Most commonly, it is intramedullary, and rarely it is intracortical or intraperiosteal. It can vary in size from 2 to 20 centimeters. It appears as an eccentric geographic lytic lesion. As in these two examples of aneurysmal bone cysts, involving the metaphysis of the radius and the diaphysis of the radius in two different patients. We can see the lesion is intramedullary in both cases with variable size, and it looks eccentric with geographic pattern. Regarding plain X-ray, aneurysmal bone cyst usually appears as a multicystic eccentric expansion of bone with thin periosteal reaction, causing geographic type of bone destruction with narrow zone of transition. Also, we can see sclerotic margins and trabeculation within the lesion. Rarely internal calcification seen. If the imaging is done in the phase of rapid growth with marked bone destruction, it can be mistaken for a malignant neoplasm. As in this example, we can see multicystic expansion of the bone causing geographic type of bone destruction with narrow zone of transition. Also, we can see sclerotic margins and trabeculations within the lesion. Another example showing multicystic eccentric expansion of bone with thin periosteal reaction, causing geographic type of bone destruction with narrow zone of transition, and again we can see sclerotic margins and trabeculations within the lesion. CT scan is helpful in delineating the extent of the lesion and the soft tissue involvement. It can show the trabeculation, and the intact thin cortex ABC shows density of about 20 to 80 Hounsfield units and fluid levels. After contrast injection, there will be no enhancement of the cystic component. As in the CT scan of the right hip joint showing an aneurysmal bone cyst within the neck and the greater trochanter of the right femur, we can see the extent of the lesion and the absence of soft tissue involvement. It is showing trabeculations and intact thin cortex. Another example in this CT scan of the lumbar spine showing aneurysmal bone cyst within the vertebral body, we can see the extent of the lesion and the absence of soft tissue involvement. It is showing trabeculations and thin intact cortex. Regarding MRI, on T1 weighted images, we will see cysts of different signal intensities representing different stages of blood products, and on T2 weighted images, we will see cysts of different signal intensities representing different stages of blood products with multiple fluid levels, with surrounding high signal intensity, which represents edema. After contrast injection, we will see no contrast enhancement of the cystic component. The septal component can show some post-contrast enhancement, giving a honeycomb appearance. The lesion appears as a well-defined lobulated contour with multiple cystic cavities with multiple fluid levels and internal septations, and a rim of low signal intensity seen surrounding the lesion, which represents intact thickened periosteal membrane. As in this example of T1 weighted fat-saturated image, T2 weighted image, and post-contrast image. We can see on the T1 fat-saturated image the cysts of different signal intensities representing different stages of blood products, and on T2 weighted images we can see the cysts of different signal intensities with multiple fluid levels representing different stages of blood product with surrounding high signal intensity representing edema. On post-contrast images, we see no enhancement of the cystic component with enhancement of the septal component, giving a honeycomb appearance. Another example of T2 weighted image and post-contrast image. We can see cysts showing multiple fluid levels, and in the post-contrast image, we see no enhancement of the cystic component with enhancement of the septal component, giving honeycomb appearance. On angiography, the ABC will show hypervascularity at the periphery, as in this example of aneurysmal bone cyst involving the tibia, showing increased peripheral vascularity of the lesion on this digital subtraction angiography. On bone scan, we will see what's called donut sign, as an increased peripheral uptake and a photopenic center. As in this example of aneurysmal bone cyst of the scapula, we can clearly see the donut sign as an increased peripheral uptake and a photopenic center. What's the differential diagnosis of aneurysmal bone cyst? Well, the list here includes unicameral bone cyst, chondromyxoid fibroma, telangiectatic osteosarcoma, giant cell tumor, metastasis, and osteoblastoma. Regarding unicameral bone cyst, it is central in location with little or no expansion, and it can show fallen fragment sign in cases of fracture. As in this example of unicameral bone cyst, we can see that the lesion is central in location with little expansion. Another example of unicameral bone cyst showing the lesion is central in location with little or no expansion and a pathologic fracture resulting in fallen fragment sign. Chondromyxoid fibroma can be indistinguishable from aneurysmal bone cyst. It appears as an eccentric expansile metaphyseal lesion. On MRI, it appears as a solid lesion with no fluid levels. As in this example of chondromyxoid fibroma, it is indistinguishable from aneurysmal bone cyst. It appears as an eccentric expansile metaphyseal lesion. Another example of chondromyxoid fibroma, again, it appears as an eccentric expansile metaphyseal lesion, and it is indistinguishable from aneurysmal bone cyst. This example shows how MRI is helpful in differentiating chondromyxoid fibroma from aneurysmal bone cyst. It appears as an eccentric expansile metaphyseal lesion, and it is solid with no fluid levels. Another example of MRI of chondromyxoid fibroma showing eccentric expansile metaphyseal lesion that is solid with no fluid levels. Telangiectatic osteosarcoma can be purely lytic, and it can show soft tissue expansion. Like in this T2-weighted MRI image, we can see telangiectatic osteosarcoma as a heterogeneous lesion with multiple cysts. However, no fluid levels are seen, and soft tissue extension is clearly obvious. Another example of telangiectatic osteosarcoma that appears as a lytic lesion with evidence of soft tissue extension, also Codman triangle, is seen here. In giant cell tumor, there will be no surrounding sclerosis or periosteal reaction. Also, usually it involves the epiphysis rather than the metaphysis with involvement of the articular surface, and it's seen in older age group, usually after the closure of the growth plate. As in this X-ray of giant cell tumor, we can see there is no surrounding sclerosis or periosteal reaction. The lesion is involving the epiphysis with involvement of the articular surface in this patient in which the growth plate is closed. Another example of this X-ray, MRI, and CT scan of giant cell tumor, we can see no surrounding sclerosis or periosteal reaction. The lesion is involving the epiphysis in this patient with closed growth plate. Metastases are usually multifocal and destructive lesions, especially in patients with a known primary tumor. As in this example of multifocal bone lytic metastatic lesions involving the right greater trochanter and the left iliac bone. The lesions are destructive and ill-defined. Finally, osteoblastoma can look identical to aneurysmal bone cyst. In the spine, usually it has calcified matrix. As in this example of osteoblastoma, the spinous process of C3 vertebra, it looks identical to aneurysmal bone cyst, but there is calcified matrix which makes osteoblastoma a more likely diagnosis. Another example of osteoblastoma of the left fibula, it looks identical to aneurysmal bone cyst, but there are minimal calcified matrix which makes osteoblastoma a more likely diagnosis. Well, guys, this was all for today's episode. Don't forget to subscribe, like, share, and tell your friends about us. If you have any comments, write them in the comment section. See you next Friday at 5 p.m. This is Dr. Ahmed Diya Abdul Wahab, and this is Highlights in Radiology Season 2. Bye.